please. All right. Well, good afternoon, everyone, and a very warm welcome to you all. It is a real pleasure to open today's webinar, which we are organizing together with our partner at the European Mental Health and Headache Alliance. European Migraine and Headache Alliance, sorry to say, not mental health. Migraine is one of the most common neurological conditions worldwide, yet its profound connection with mental health is often overlooked. For many, the burden goes far beyond physical pain, affecting emotional well-being, daily functioning, and quality of life. By bringing together expertise, research, and the voices of those with lived experience, we aim to shine a light on this comorbidity and the urgent need to continue to address it. Over the next 2 hours, you will hear key findings from our last 2 reports, personal testimonies, and contributions from leading clinicians. Today's program is designed not only to share knowledge, but also to inspire action towards more holistic, integrated care and better support for all those affected. On behalf of GAMIAN-Europe, I would like to thank you for taking the time to join us today. Your engagement is vital in advancing this conversation and ensuring that migraine and mental health receive the attention they deserve. Before I pass on to Elena, who will lead today's conversation, I would like to thank our supporters for standing with us and helping us to make a difference. I wish everyone a fruitful and thought-provoking session. Elena, over to you.
Well, thank you, Nigel. Thank you very much. Thank you to everybody, but to the speakers for telling us today some new funding, some new information about this important relationship between migraine and mental health issues, mental health problems. In our discussions, Nigel, Chiara, and myself, I always defend that migraine is not a mental health problem. It's not a mental health neurological disease. It's a neurological disease. But it is true, and we have to accept that migraine leads us to many mental health problems, such as depression, anxiety, we cannot live. We get so fed up of this pain in our head of not being able to live that at the end you get into a mental health problem, and then you have this bipolarity between the mental health issue or problem and the neurological condition, and then you go to a different doctor, they send you to a different doctors, and then you start taking tablets for one thing, for the other, and then your life can become a mess. And this is exactly why I think it's very important that we have those webinars to clarify, to understand better how our brain works when we have a migraine and why we go into this problem of the mental health diseases. And it's also very important for us because the more information we have the patients, the better we can lead our disease or our condition afterwards. So information, it's principal, it's very important, and we really need to have it from the best experts in that we know. So that's what we have tried to organize today. And in this webinar, we are going to, I don't want to be long, I just want to thank you all, thank to Gamian for your interest always and being together with us. I see that Professor Dimos-Mitsikostas has just joined the meeting. Welcome, Professor.
Thank you very much for the kind invitation.
Thank you very much for being here with us today. I should have to give the floor to Chiara, but I know you are very. Chiara, you want to speak now, or is it long your speech? Because then I know Professor Dimos-Mitsikostas is in a hurry, isn't it?
Okay. I'm happy to chat.
That would be great if I had the chance to deliver my, small lecture right now. That will be very helpful for me. If that does not disturb the structure of the meeting.
It's fine. For me, it's no problem.
It's okay. Let's do it like this because we have key findings afterwards from Chiara, but I also know very well your schedule, your days, and so I give you the floor, Professor Mitsikostas. Can you tell us about your new study about the relationship between migraine and mental health diseases?
Yeah, absolutely. Thank you so much for inviting me once again. Let me try a little bit to share some slides. Show I captures where how can I do that? Share, okay. 3 share.
That's
Or
it. That's it.
that's it.
No?
Let me see.
You have it, Chiara.
Okay.
I have
Yeah,
it.
here we are.
Right.
Here we are in. All right. So I'll talk a little bit about the connection and the comorbidity between primary headache disorders and depression-like, because it's not only for depression the interest. Several other anxiety disorders or depression-like disorder like bipolar disorder are also involved. So I'll call depression-like symptoms or anxiety-like symptoms that are present, and about the frequency and the prevalence of those symptoms in several types of primary headache disorders. So that's the issue, and those are my conflict of interests, both financial and non-financial. Just to mention that there are some connections with the industry that they are sharing financial interests in therapeutics for migraine and tension type headache and cluster headache. So how can we study the comorbidity of depression and anxiety? One way is to go and see at once in one given point the co-occurrence of one and the other disorder. And there are other approaches as well that they study the co-occurrence of those two disorders after several endpoints. We call those longitudinal studies. In that one, I'm presenting here the results. It's very old study. I was so young at that time. Published in 1999, but it was a control study, and here you see the odds ratio of diagnosed according to IDSM-4 that time depression disorder, major depression disorder, and you see how many times more often the major depression was present in people with any kind of primary headache versus a population of non-headache people. 8 times for all kinds of headaches primary. That was the case for migraine in total, but when we looked for migraine with aura, it was 18 times. In migraine with aura, without aura, it was much more less, 5 times. In chronic tension type headaches, 16 times more often major depression versus to people they had no headache. Mixed headache, that time we didn't have the term chronic migraine, but we used to call all those very prevalent migraines along with tension type like headaches, mixed headache. So, and now you see the odds ratio goes up to 19, and the incredible co-occurrence was in the medication overuse headache. You see 36 times more often the co-presence of depression, of major depression in those people versus those they had no headache. So that was an amazing finding. But that was a very old study. So we wanted to see what happened in our days in a really large population. That one was around 500 people versus other 500 people without headache. So we collected data from more than 2,600 people with any kind of primary headache. We scanned them with the Hamilton anxiety for depression and for anxiety scale of Hamilton, and we collected the data and we did the comparisons. The paper published last year, and you see here this was the control. 460 people without any kind of headache, and here you see the episodic migraine, the chronic migraine, the episodic tensiotype, the chronic tensiotype, the episodic cluster headache, the chronic cluster headache, new daily persistent headache, other primary headaches versus control. All kinds of headaches, primary, had more often depression scores for the Hamilton, with the exception of cluster headache, which was a very important finding. We found a small increase during the boots, but generally those people, they didn't show anxiety or depression like symptoms, but they did express other let's name it psychological signs, and they were diagnosed much more often with bipolar disorder and other mental diseases, but not mood diseases. Here you see that females expressed more often this co-occurrence with any kind of either anxiety or depression-like symptoms. And that was the case for education. The lower education you had, the more prevalent the anxiety and the depression symptoms we found. Here you see the anxiety scores by headache type. The previous one I showed was about depression. Again, the same pattern. This is the control group. All primary headaches, with the exception of either episodic or chronic cluster headache, they had more often the presence of anxiety symptoms. Another longitudinal study was that one that published a couple of years ago. It was a 12-month follow-up study and included 130 people, but it was only an exclusively focus of chronic tensiotype headache. And they found that the effect of baseline pain interferes with emotional burden of headache at 1 year after 12 months, and was mediated through baseline depression, whereas the effect of baseline pain interferes on the physical burden of headache at 1 year, and that one was mediated through baseline emotional burden of headaches. So all these tell us that we have to pay much attention for the co-occurrence of those anxiety and symptom and depression symptoms in a patient suffering from any kind of primary headache, in particular those they are suffering from chronic types of headache, and scan them for this co-occurrence and treated them in accordance. This is a very recent study. One of the monoclonal antibodies we are using for the prevention of migraine has been shown that is active not only in reducing the monthly migraine days, as you see here, or the 50% responders ratio, but also in the same time, in a parallel time, decreasing the symptoms of depression, telling us that we have medications to target both conditions in one person, both migraine and both depression. And that is only the start, because in the future, I have the sense that we will discover many other treatments that we will target both conditions. So in synopsis, migraine and other primary headaches are strongly associated with depression and anxiety. And this increases headache burden, as you may imagine, and impact decision-making in therapeutics. If we have medication that may target both conditions, we have to use them, or we have to use a double treatment, one targeting for to migraine and another one targeting to depression or anxiety symptoms, because there is an interaction between those two conditions. And if we treat migraine and leave untreated depression or anxiety, then migraine will relapse again. So that's the meaning I wanted to deliver to you. Those are my colleagues at the Headache Ignition Clinic. My colleagues, I thank them, and I also thank you and the organizers of this meeting. And if there is time, I may take questions if the chair allow that. I can't hear you.
Yeah. I was muted. Sorry. Yeah. Well, Dimos, thank you very much, because this is a really, really interesting survey and research. Extremely important. We have claps of hands in our answers here. So it's general that yes, I see that it's not only important, is that it's maybe the starting point to research more, furthermore, about the relationship between migraine and mental health issues, depression or anxiety. And one thing as a patient that I could say is that the more severe you are in migraine, the more easy is that you get depression or anxiety, because when you have so many migraine attacks, you are fed up of not getting rid of it, and then it's when you go into a depression or an anxiety or a depression.
Absolutely, Elena, I agree. We don't know which cause each other, because the way we are, causing and developing depression in animals is to put them under chronic pain conditions. We start with a small daily headache pain, either with electricity or with any other physical means to cause pain to the animal. And we see that gradually and progressively, after a couple of days, then the animal is isolated, doesn't drink, doesn't eat, doesn't interact with other animals. It becomes depressed. So that's the way we induce depression in animals. So definitely there is an interaction between those two conditions. So that's why my message was that we have to take care of both.
Yes, and I completely agree. And it's important what you said. I want to remark what you said about the treatments that could be useful for both diseases. And because sometimes when we have migraine, we take our tablets and then they send you to the psychiatrist or psychologist, especially psychiatrist, and they add you more treatments or different tablets for your situation, for your mental problem, and then we also know that getting too many medications is not good at the end. At the end, you have all those side effects from each of the treatment that you take, and it leads you to a even worse situation or even a chronification of the situation.
Absolutely. And normally you are getting, tired of taking so many pills every day. That happens in all of us. I mean, we have, an infection, and we are taking antibiotics, and after, 2 days we are, bored. I mean, again, the med. So imagine someone who is taking, every day for years something. So it's a normal reaction, I would say. So that's why adherence is so low, apart from other reasons you just mentioned, like the intolerance and other toxic like adverse events.
Right. So let me say one thing. In the agenda, we had questions and answers at the end of the day of the webinar, but you need to leave before. Let me open the panel for if anyone has any question from outside, and they could put them there. And Chiara, can you help me with the questions if you see that there is any question from our audience today? Because I think it's a very important topic. It's really, you get desperate when you have a chronic migraine or a period in your time in which you have those recurrent migraines that you cannot get rid of them. You get desperate, and then you start taking all the tablets, and then you start taking all those side effects, and migraine doesn't get go away, and depression either, and it's like a snowball that grows and grows in your life, and you are lost there. How do you recommend people to act if they are in one of those situations?
What I do is because I want to handle all medications that interact with the brain. If it depends of the severity of anxiety or depression. If it's a mild condition, after treating effectively migraine, it might goes away. But if anxiety or depression are really strong when I'm seeing a patient for first time, then I offer either two treatments, one for depression or anxiety and another one for migraine, or lately I'm using the monoclonal antibody that may affect both conditions simultaneously. And in most cases, I'm also suggest for cognitive treatment that helps a lot as well.
Okay, yes, right. Sorry if there's someone saying that they are hearing some echo sound during the speech. Is that persistent again? Do you also have echo?
No, I
No,
don't have.
I don't have
Okay,
an
there
echo.
is one person asking if do depression or anxiety symptoms improve as migraine improve when treated properly?
Absolutely, I believe this because, as I said before, each condition interacts with the other one. So you may see a decrease in anxiety and depression symptom when you control the migraine attacks. But if there is a genome, then you have to treat separately the anxiety disorder or the depression disorder.
Yes, right. I think it's not the same. It interacts, but it's not the same. And you need to know
Absolutely.
yeah, you need to really know to brain on your to know your brain and your body and your brain. We have another question for you. This one asking, what does the professor think of on the amount of days taking medication causes overuse headache? How many days a month is too many?
Well, it depends on of the symptomatic medication that someone is taking. For instance, if it's a triptan, then we consider more than 10 days per month with with at least one tablet per day of a triptan. That causes medication overuse headache. Whereas when we are talking about the analgesics, that goes a little bit upper at 12 days. But in any case, I would suggest, and that I'm doing in my clinical practice, not to take more than 2 days per week any symptomatic medication. Otherwise, the risk of medication overuse increases dramatically. And that's why I'm insisting for very efficient symptomatic treatment. And I'm always suggesting not always one symptomatic treatment, but always a rescue. So if migraine does not go away after the first treatment, have another one like sumatriptan subcutaneously or a nasal spray, something that bypasses the gut in order to act more rapidly and resolve the migraine attack.
Yeah, right. It's important to know an expert in migraine when you need to be treated, because it's those tricks that you are giving us are very special, and you only know them. We are used to go to a doctor, GPs, or even other neurologists, and they just follow a protocol and they don't know anything, or they don't know what to tell you, or how to say, how to help you in a bad situation. No, the problem here is when you get into this dark side of the migraine and depression, and then you are in a bad situation.
That's true. The comorbidity migraine with depression or anxiety needs a specialist. That's true.
Yeah, needs specialists. And I guess you are going to present those results in many other congresses or conferences, and you're going to engage neurologists and people to know a little bit more about this relationship and this way of treating it, because we really need that people is prepared for that situation. And it's the prevalence, I think it's much higher of what we think. What do you think?
Yeah, absolutely. As I saw the results from my cohort, it was incredible higher, and that happens. I mean, if someone reviews the literature, you will see exactly the same result. The higher coherence of both depression and anxiety disorder in people suffering from migraine or chronic tension type headache or medication overuse headache. Some studies pointed out an increased frequency in cluster headache, but not only angry.
Yeah, because cluster headache is another one. I always say I speak about migraine, but cluster headache is even it's another one that is very complicated.
It is, and has relations with behaviors, particular type of behaviors, etc., etc.
Yeah. Well, so I have to thank you very much for your time and for your research. It's always a pleasure, our honor to have you here. I know how busy you are. I know how you are. I have to say that Professor Mitsikostas is always on the side of the patients. Whenever we
Absolutely.
Yeah, whenever we call him to help us in a research or in a new project, he always says yes, and that's very special. And I really want to give you a special thank you and special. I'll send you a special hug from here.
Thank you so much for inviting me. It's always a pleasure to talk to your people and to see you always, you personally, Elena. Thank you indeed.
Thanks a lot. Let's move on with the agenda. If there's any other question that comes in the blog, I will send it to you.
Perfect. Apologies,
You
I have to leave, but I have some other commitments. But once again, thank you so much, and thank you for your understanding. Thank you.
Thanks to you for participating. Please.
Bye-bye.
So, Chiara, I'm going
Thank
to
you.
give you the floor. Yeah, bye.
Thank you very much. I will go to my slides now and present to you.
I suppose that I presume that we all have the agenda in front, and I'm not going into the title of each of the topics, but I know that we all have the agenda. So, but of course, Chiara is going to speak about some results and findings that we have in some reports.
Mm-hmm. Yes, what I'd like to do, thank you so much, Elena, for introducing me, and thank you very much to the previous speaker. Very interesting findings which very much overlap with the findings from these two reports, which we jointly did with you, Elena, which was a great pleasure to work with you and your team. So these are two reports that I would like to tell you about and the key findings from them. And so what we were looking at specifically was, again, the comorbidity between migraine and mental health. And really, the whole emphasis is also on a call for integrated care. So we're starting to see much more of that in terms of, you know, what's needed and what's being demanded in a way. So as I mentioned, I'd like to talk about these two reports. The first one was focused on women, and what we wanted to do was raise the profile of the link between migraine and mental health and really look at that connection and what it was to have the two together. We wanted to understand people's experiences of this comorbidity and to also understand how it impacted on their quality of life. And then we wanted to look at the care that they received from services, from health services, and what their treatment experiences are and were. So what we did was a survey of just nearly 260 women. And what we found, and here are some of the key findings, we found that 77% of the people that responded to this survey had been diagnosed, and this is a European-wide survey, had been diagnosed with some sort of mental health condition, and has been explained already by the previous speaker, was mainly to do with depression and anxiety. We found that 25% reported that their depression or anxiety was connected to their migraine attacks in some way. 90% took prescribed medication or had bought their medication from their local pharmacy, mainly to treat their migraine attacks. And only 30%, interestingly enough, took antidepressants or received some sort of cognitive behavior therapy or talking therapy, as it's generally known, for their mental health. So already you're starting to see potentially a sort of under-treatment of mental health symptoms. So what was the impact on daily living? Well, from what people told us in our survey, it was a huge effort. It was a huge effort to function day to day, to do things, sometimes even performing basic daily chores like some basic housework or taking children to school became very difficult. Going to work was a very difficult thing to do day in, day out, and just spending the hours at work and being able to just do the things that they had to do. People reported a lot of tiredness, fatigue. Many respondents talked about a lack of social life and generally a very poor quality of life because of this co-occurring condition. People were very fearful of making plans for social activities, or even going too far from home for fear of having a migraine attack. And the depression side of things made women feel even more worthless, and that they just found the whole thing, when the migraines came on top of them, that it was just exhausting. I think you get a general picture of kind of what it is, but I'll go into more detail a bit later on. Contact with services was quite challenging in many ways. We found that 48% of our survey respondents were seeing a neurologist for their migraine attacks, and 16% were seeing a mental health professional, which was interesting given that many had been diagnosed with a mental health problem. So it looks like perhaps a lot of this is being managed by their GP or in primary care, as it's called as well. But that also presented some challenges. So people who would go to their GP and explain about their migraine attacks, and sometimes the GP didn't really listen well enough, let's put it like that. And often, you know, they would dismiss it as a headache or not really understand or not really hear what they were saying. So this person here talks about how GPs really need to be educated about what chronic migraine is, and that it really isn't a headache. So in terms of actual treatments, and this is for migraines specifically, this lady here talks about how she's tried almost all the treatments for her migraines and found that there were side effects for all of them. And that was another key theme, another key area and a challenge for many people. The whole thing of treatment side effects, and often that was dissuading people from taking medication sometimes, or they would have to keep changing to find something that worked a bit more effectively, but also didn't have the side effects that they didn't want. Interestingly, and I'm always really interested in this area, is about the strategies that people find for themselves often, or what they hear from other people who experience the same co-occurring condition. And the strategies are kind of so varied, and I won't read the list out because it's quite long, but often included things like using alternative remedies, maybe vitamins, maybe massage, meditation, outdoor walks, doing lots of kind of perhaps trying out diets, eating more healthily, trying to have a bit more of a flexible work routine, and knowing about triggers. That was a really big important one. Really understand what the triggers were and really try to manage those. And where possible, take regular exercise. And that was quite key where it was possible. Some people found that actually quite challenging as well, so it wasn't always appropriate. So in our second report, what we wanted to do was, here we kind of delved a bit deeper into what we found in our first report. We wanted to look a little bit more at the frequency of migraine and co-occurring mental health conditions. And we wanted to look at the relationship more specifically around this comorbidity, and importantly, to really try to highlight the economic, human, and social costs of this co-occurring condition. So what we did first was a literature review, looking at the evidence and pretty much kind of looking at the sort of evidence that the professor previously presented. And what we found was that people with migraine are 2 to 5 times more likely to have depression and anxiety disorders, which also includes poor sleep. Which kind of, if you like, worsens the issue, if you like. Depression was also found is a predictor, basically, of chronic migraine. So we're starting to look a little bit more at this bi-directional relationship. We don't know what causes what, as the previous speaker mentioned, but we do know that the two are very closely connected, very closely related. And many researchers agree that this is a bi-directional relationship, they call it, where migraine can increase the risk of a mental health condition, and vice versa, where migraine attacks can actually lead to more symptoms of depression or anxiety, or both. In terms of the economic costs of migraine and mental health conditions, it's quite difficult. There's no specific study that has actually costed this comorbid condition specifically. So what we did was we just looked at what the costs are in terms of migraine, what this costs the economy, what this costs the workplace, if you like. In Europe, in a study that was conducted in 2014, we found that the costs were estimated for migraine to be in the region of 50 billion euros. And in the UK, more recently, a study by Martins et al. Found that this was, in the UK alone, was 12 billion. The costs of mental health conditions is really high as well. When you look at it separately, you can see here that estimates include something like 330 billion, and the actual healthcare costs amount to about 60 billion. So these are not insignificant sums of money, and something that we really need to grapple with quite quickly. We can't waste time on this, really. And when you look at the costs of chronic migraine, these are 4 to 8 times higher than for someone who experiences episodic migraine. And a lot of these costs, between 77% to 93% of all these migraine related costs are due to work absenteeism and reduced productivity. So again, these are extremely high figures and something that, cannot be ignored. When you look at the cost of this co-occurring migraine and mental health condition across Europe, you can see that there are country variations, if you like. So if you look at healthcare costs in particular, you can see that in the UK, it seems to be slightly less than it is for Italy, where it's 1.6 times higher in terms of healthcare costs. I'm not entirely sure why. I think it's not entirely clear as to why that's the case. But it's an interesting variation to be aware of. So we were quite interested, coming back to the whole experience of migraine attacks. Well, what does it mean to have a migraine attack? What is that like? And when we talked to some people who participated in our workshops for this project, we said to them, so what is it like? And they said, well, actually, for me, my first migraine attack was a bit like having a stroke. Gosh, I mean, that's it, and that wasn't dramatizing it by any means. So we have a lady here who says, oh, my migraine attacks lasted from anywhere from 6 hours to 6 days, and it almost seemed random as to how long these attacks could last for. And she would experience cognitive problems, thinking problems or thinking impairments, speaking impairments, and of course it came with a lot of pain. And it was interesting when we did ask this question. One person said to us, well, actually, nobody's really asked me what it's like, what is it? And she said, well, actually, I can describe it. Often when I get a migraine attack, I'm pacing the room and I start hitting my head on the wall. Sometimes my husband has to actually come in and stop me doing that. So again, these are not, ways of being dramatic. These are kind of what it is to experience. So it's very debilitating and very, very painful. And then when the attacks are unexpected, the impact again is considerable on quality of life. It affects my family, it affects my children, it affects the work obligations and everything else that I have to do. And on top of that, it just makes me feel anxious and depressed. So we need to really address this quickly. Just to reiterate a whole point about connection between migraine and mental health, we had people who talked about what that meant for them in their lives. The migraine definitely makes my depression worse. And when I go through a bad episode of depression, that makes my migraine worse too. So it's a vicious cycle and it keeps going round and round. Sometimes it starts with one and then goes to the other and then vice versa. So, what people tell us happens to them is very much kind of reflected in what the research says as well. What's interesting here is that this lady was saying that my mental health improves a lot when my migraine attacks decrease. So coming back to the previous speaker's point about, actually, if you treat the migraines well, it can help with the depressive symptoms. And this person was actually saying, well, actually, my mental health problems are because of my migraine. So you can see a sort of almost a causal relationship there. And interesting that some people don't always recognize that connection. So this lady here at the end says, I realized I've been living with migraine all my life. And then there was the mental health part, which has always been there, but I never fully realized. And I never realized that they were connected. So that's a kind of important realization as well. So just some of the key points from when we heard about the lived experience of migraine and mental health conditions. We found that self-blame, often people actually felt responsible for their conditions, which added to their stress. Stigma and discrimination are a huge problem, and the lack of understanding that people often felt, say from work or from their colleagues or their employer, was something that, was described quite a lot in our work. And not being believed, GPs sometimes wouldn't really believe the full extent of how difficult it was to have migraine attacks, plus try and live a normal life, plus try and keep up with all their responsibilities. So just on my last slide here, I mean, I can't emphasize enough the urgent need for this sort of integrated and holistic care, because many of the women and people we spoke to talked about how, as Elena described earlier, going from one service to another to try and get some of their symptoms treated, and then the other ones would be put aside until they had an appointment for the others. So we need some sort of integration where both can be, looked at and addressed at the same time. We need to address this whole misunderstanding of migraine, and to help GPs kind of really understand what it means to have a migraine attack and how and when to sort of provide the right treatments, and also to refer to neurologists a bit more quickly. I mean, there was also an issue around waiting times to see a neurologist, as we know that there are. I think the mental health side of things tends to be delayed as well, and sometimes overlooked, which is quite concerning. And that disconnect between each of the sort of specialist departments is really causing some major problems for people who experience this comorbid condition. I'll stop there because I'm sure we're pressed for time, but thank you so much for listening and your time and for joining. Thank you.
Thanks to you. Thanks very much to you, Chiara. It has been very, very clarifying, and those data have been great to understand what's going on in the field. I think, and you have put so many testimonies of people that have gone through it, and there is so many people like that. I have to tell you that every time I was listening or hearing something that you said about those testimonies, I was like, yeah, exactly. I had the same feeling. We have all gone through those periods of moments in our migraine life that we have been very, very bad, very severe, chronified without being able to get rid of it. And then in that situation of I'm depressed. I don't want to wake up in the morning. I don't want to do anything. I can't. In fact, it's not that I don't, it's that I can't, and then I give up. And it's very important that people know that situation, because we need to create tools and try to help and know how to help people not to give up and to fight and to know now how to get rid of it, and that it is possible, that there is a possibility. It is possible. You have to be well treated, and then a well follow up, and then you get out of it. And it's true that we need good support from good specialists, practitioners that know what they are speaking about, that understand you, that they don't. And we need to lessen a little bit the stigma that there is around both mental health problems and migraine. Both of those conditions have a huge stigma around, and it's important that people start respecting that situation and supporting those patients, because once we feel supported, immediately you get a little bit better. You know that there is a possibility.
There is that hope, and I completely agree with what you say. And I think it's really important that we start to kind of really develop those support systems. It doesn't have to just be from specialist services, because we know how hard they can be to access, and it takes such a long time for many people. But I think also, from peers, from other organizations, like yourselves, pointing people to groups, communities that can be supportive as well. That can be very
There's a
important.
question here now, Chiara, that I'm going to put it to you, but I think it's going to go to our the professor that we have afterwards. But it says, has migraine and related mental health increased with COVID?
Oh,
Are there any studies on it?
it's a very good question. I
Very good
don't know.
question.
The truth is, I don't know, but I suspect there may be something there. Yeah, I'll definitely look it
The fact
up.
from the patient organizations, we know that there has been a huge increase of migraine.
Yeah,
COVID worsened the migraine situation, and therefore
yeah.
mental health issues came along.
Absolutely. I was just going to say, the mental health side of things definitely increased during COVID. We saw a spike of really skyrocketing skyrocketing rates of anxiety and depression. Yeah, with COVID, with the which actually spiked a lot during lockdowns. So I think, and also interestingly enough, eating disorders was on the rise during that time. So there was something about lockdowns that really didn't bode well with people in terms of their mental health. And I think this is just not just people with existing mental health problems, although it affected their symptoms, it worsened their symptoms as well, but people who had no previous mental health difficulties and then found that actually they were developing them during COVID. Yeah.
Yeah, yes,
That's
yes,
all I
yes.
can really say for that. Yeah.
And
What
there has been a headache, a persistent headache after COVID that is also
yeah.
very, very
One of those
driving.
long COVID conditions. Yeah, because there's been quite a few. So yes, there may well be.
Mhm. Annette is asking us, people with a chronic migraine are 2 to 5 times more likely to have depression or poor sleep. Poor sleep is a risk factor for dementia. Are people with migraine likely to have dementia at some point?
Oh, Elena, maybe that's a question for you. So as
I hope
somebody, I'm a
not.
researcher in mental health, I should add, I should have said this before, so I don't know the big details on migraine, but
I want to think that no. I want to think that migraine is not related with the dementia or Alzheimer or any other issue. I want to think that all the opposite. And when I have been in the congresses, I am a very positive person, and I always want to listen to those one who um, who speak about that that hypersensibility that our brain has for the bad, for those brain attacks, but also for the good, to tell us that something is going wrong and to be advanced to other diseases, or to recognize changes in our body, in our organism, in our brain before anybody else. So I always say that my brain is protecting me, which is protector, is protecting me from other things. I don't really know the exactly date, the data, but I'm going to give the floor to Reto Agosti, that we has joined the meeting now, because he's a doctor, he's a professor, and they know a little bit more from the science point of view. So Reto, are you hearing me? Reto? They are talking, but they are not listening. Yes.
Okay, can you hear me
Okay.
now?
Yes, perfect, Reto.
Oh, wonderful. Wonderful. Thank you. Thanks, Elena, for the invitation. And thanks for the collaboration. Anyhow, so it goes back several years now, and it gets intenser and better every year. And also, really thank you for this invitation now to show kind of like the clinical perspective of my thoughts on mental health. Just waiting for my slides. Can you see my slides?
Yes, we can. Yes.
Okay. I hope I can move my slides and point in the slides.
We have the first one, the presentation one.
Okay.
Now, second one. All
All
right.
right, perfect. So, all right. So this is my clinical setup. So we have three sites. This is the main office. In the first floor in Switzerland, it's the second. It's in first floor in the US, and it's the well, so I don't know if I can show you that. So that's where my practice is. We are 10 physicians at the moment, 8 neurologists, and one in training and one for medical studies. And there are 8 treatment rooms here, and the upper floor is a cooking lounge. It's where I am at the moment. It's also perfect for webinars and things like that. Then we have a second site in the city of Zurich, so that's especially for people working in the city or coming from externally by train. And there is a small practice also in Basel, because that area is also underserved in terms of migraines. So I would like to span the bow of mental health a bit wider than focusing on depression and anxiety. Of course, that's also extremely important in our practice, but mental health has, for me, a slightly different concepts. And I would like to distinguish mental health with and without psychiatric disorders. And this is kind of like the spectrum that we see in it. At least is certainly not perfect and not complete. But we also deal with personality disorders, suicidality, we have some schizophrenic disorder. Autism spectrum is also present in our migraine patients. And of course, ADHS, ADHD, and sometimes violence, though very, very rarely. So speaking of my team, we have founded the headache center, the Zurich Headache Center, which is embedded in the biggest private hospital group, here's London. That's why there's this double name. So we have seen about 30,000 patients in the last roughly 20 years. And of course, the spectrum of disorders we've seen is really big. So mental health for me is emotional, psychological, and social well-being. And there's even more components than that. That's the official definition by AI Google. And of course, it's encompassing ability to handle life's stresses. And I think this is one of the most important terms to use in terms of mental health. So it also has to do with their own potential work productivity and also contribution to your own and the public. It's a dynamic process, of course, and we are in the middle of it in our practice. So this mental health aspect has, of course, different components. It's an emotional, a psychological, and a social well-being. And I'm happy to repeat it. Practically all of my slides you will see as an anchor, and it impacts daily life. It has a meaning for your overall health. And of course, it also promotes resilience. I'll skip that and go into migraine and depression. So we have heard two wonderful presentations now by Chiara, Samele, and my old friend Dimos-Mitsikostas. And there's an abundance of scientific information on migraine, starting back probably 100 years, and certainly the landmark studies done in Detroit. And now there are numerous other scientific. So I don't want to focus only on depression and anxiety, but there is more. So anxiety has also to do with anxiety, not in psychiatric disorders or in terms of anxiety from next attacks, anxiety leaving home without enough medication. Anxiety about missing out job performance, sports, leisure, family events, etc. And of course, anxiety over general worsening of the migraine in terms of a negative disease modification. Migraine certainly has also an impact on cognitive dysfunction. There were 2-3 wonderful presentations and posters last week in Sao Paulo at the International Headache Conference. So I don't want to go into these, but it's also a bidirectional relationship between migraine and cognitive functions. Migraine is strongly influences the good mental health. So also now talking on migraine and mental health and their relationship. So there is also a bidirectional relationship. Migraine influences mental health, and mental health, of course, is influencing migraine, talking about migraine behavior and the point actually that Chiara or Samele mentioned, that she is interested in strategies of patients. So do I in the last 25 years doing intensely migraine work. So migraine depends also on good mental health without psychiatric disorders, of course, also with psychiatric disorders. And our main kind of like core activity in my practice in the last 25 years is individualized. And I say this word once again, it's individualized caring for good mental health. And that's really our core in my practice, of course, next to standard medical care that we do, of course, as well. So I take a few minutes to go through some points of why I think basic mental health is very important for migraine care in my practice. So my task is actually to talk on the clinical side, and that's what I like to do with the next few slides. So one core element of being successfully treating patient, speaking of 30,000 in 25, 22 years, is of course that we have enough time for our patients. So we listen to them. Migraine is an oral medicine. So we still now, despite more and more restrictions by our medical tariffs, we take still 60 to 90 minutes for each new person. My old teacher, Hans-Rudi Isler, some people might know, did the same, and I keep this up. And 60 minutes is certainly very tight. 90 is a bit comfortable, and we try to maintain this interval. And then we have a 30-minute interval for follow-ups. Usually speaking time is, of course, at the end, 20 minutes if you have a tight schedule. But we listen to them. I'm very curious about their stories. And even now, with my quite long experience with working with migraine patients, my curiosity probably will never end. It's certainly fully running. And my motive is also, I learn something from every patient. And of course, sometimes we talk extensively on migraine auras. It's a funky topic I like really a lot. Doing like a mental tour through the brain, of course, all those cortical areas and variations. But there have interesting jobs. I ask for the jobs in every patient. I also ask about their families, maybe where they live. Sometimes the patient look at me quite curious and say, why do you want to know all this? And said, well, it's part of your migraine. And I know the families after these many years sometimes extremely well. And many of my patients that don't have a primary care because they come and see us referred from family, from friends, from workplace, through social media. They come to see us because of a migraine. Often they're young, typically they're 20, 30, 40 years old. Often we have expats in Zurich, so working for university, for Google, for the airport, for the banks, and they come to Zurich and they don't have a primary care. And it's also difficult to find a primary care. So it's kind of our function to be a primary care to them. So sometimes I call myself a neurological primary care doctor. So these are really, really long patient travels going through, sometimes through their life, certainly up to now 30 years back. 2 or 3 patients even joined me after 8 years training in the USA and came back. Those patients I have seen as a resident neurologist at the University Hospital of Zurich. And of course, they found out I was back and they came back. So that's now it's more than 30 years now. I do headache diaries. I study them. And also it's an important point to my young physicians, please ask for them. The migrant people are reliable, they do their scans, but they're kind of like shy and hesitated to show you their diary. So it's often in the handbag, and you ask them, have you done a diary? Then they show you the best documented migraine stories you can imagine, but if you don't ask, they're too shy to show it. So it's really important, ask for the diaries. And then next thing, it's kind of like technically very important, but it's also symbolic. I scan them myself. So I have a flatbed scanner, a very simple one, USB driven, and I scan the diaries by myself. And then I look at them sometimes on the screen, but very much also like to look at them on paper. There are numerous scientific drawings around. Most of them are out of my migraine book that was published 10 years ago with Hans-Christoph Diener and Volker Limrod and 25 other co-authors, but it contains 60 new scientific illustrations. I paid a scientific illustrator for 2 years in my practice, so she had one of my offices as her studio filled with books, drawings, skeletons, and all kinds of things. So I use this illustration to communicate with my patients. And the nice thing is, of course, these illustrations are done for migraine, because many of the scientific, anatomical, and physiological drawings, they lack, of course, very important migraine details, speaking on the world of things. Then we have an environment in my practice. It's a warm environment. It's spacey. It's light in practice. I have most of the rooms, all the patients' rooms where the physicians work, they have all a very nice wooden floor. And I have a lot of arts around. I like flowers. And in brackets, I recommend orchids, because if you care them carefully, not too dry, not too wet, they keep flowering sometimes for months in your practice. So it's really actually a practical point. It's nice to have something live like orchids in your practice. These are all like hidden messages that patients are welcome, and we like to work with them. We work casual, not in clinical white and shiny. It's not a clinically white and shiny environment. It's kind of like casual. Each room has also its own color. So they have the standard furnitures, but there's a stretcher and everything, but there is a sideboard where each physician was able to choose their own color. It's a little like a touch of color in each room. And each room also has art, and I think it's also important that art is chosen by doctors. So I have a small collection. Many of the art are hats, strange hats, funny hats, interesting hats. One is a huge paper cut through a brain. So those things accompany us as well. Then we have 2 windowless rooms, more initially for space, but for migraine patients, they're really, really important. So you have a room without daylight, because most of the patients are photophobic and phonophobic. And also we like to treat general emergencies, migraine emergencies. We like to use IV medication, being it valproic acid, magnesium, some other treatments. Unfortunately, I don't have a person who is doing ketamine in my practice. That would be really, really nice to have. It's difficult to find in Zurich. We have a casual dress code, so we usually don't work in clinical white. So that's kind of like the American model, where you actually work in a suit and a dress. And it has also advantages, because you don't have to care for uniforms, wash them, have them ready, any size. So every patient, every physician, and my team have to change the clothes every day. And of course, we use name tags, because we are in a casual dress code. That's also very important. My physician's assistant, so that's a tricky word. Those are the girls working usually at the desk and doing IVs and giving out medications, doing paperwork. They're also selected by interest in headaches. It's very important. I'm very, very lucky to have a very friendly team. I get really so nice feedbacks from the patients. And, these patients come in sometimes really for years, sometimes more than once per month. We have regular intern and external reunions, and we do teachings. And everybody likes actually to come to work, actually causing me tears to have such a nice team under such nice conditions. But I can tell you, the patients, they feel the same. It's important for their mental health. So I have 7 board-certified neurologists, including myself. One is pre-board, one is a resident physician. He was writing all my medical reports, and he's a really fine character and very interesting person. So we hired him as a resident physician. And then I have one doctor who's doing only pharmaceutical studies. So that's a special title in Switzerland, like in other countries as well. And each physician is also a subspecialist, being in sleep, epilepsy, MS, dementia, movement disorders, and some others. I have a 60% job, Barbolina, who's only doing communication. She's a professional. She studied publicistics, I think, and communication at the University of Zurich. And I can tell I hired her as a patient. She was pregnant for the 2nd time, lost her job of the city of Zurich, and hired her as my communication person. I said, hey, look, You don't have to clean my office, like she said. I just want to work. I want to work 30%, but I can't because of my kids are at home and my husband is doing a career, which is okay, but I want to work. I clean up your chaotic office. I said, no, you don't have to clean up. I do it myself, or we do it later. I give you a website specialist for a month, and within a month I had a brand new website. So it was a 20% job. Now it's a 60% job for 10 years. And look, we're still doing last week, European Migraine Day of Action. We do this now for probably 8 years, and it gets bigger and bigger every year. So last Friday, while I was in San Diego, my team organized a public evening here. You see 150 people, 160 people in a kind of like a reunion room in a hotel in the city of Zurich, and we had 200 other people online, and it gets better every year. And I think that's a really important also communication and contribution to mental health of my person. Well, mental health, of course, is a wide thing, and I have been confronted with suicidality, but unfortunately also by a few suicides. A medical colleague, migraine was certainly a part of it. Another young man jumped out of the window when he heard he had to go to a rehab because of his migraine. We have a lot of like so-called long-term cases without hope, but we follow them. We're there we are here for these patients. And like an old psychological friend of mine, the first like systemic and family therapist of Zurich with 10 years experience in the US, she also kind of like quoted this little thing and said, you know what? It also needs people that are standing together with your patients at the abyss. And we do this. And I think with success. And in terms of migraine, suicidality, and depression, I can refer to Marilu Selo Foundation. So I'll go back, and I think this is a really nice shot, and I like to finish with this quite wide bow of clinical facets of mental health in migraine. Thanks for your attention.
Well, thanks a lot, Reto, for your presentation. And congratulations. I have to congratulate you for so many innovative situations around the treatment of our patients. It's important how you treat how do you treatment, but I found very interesting this innovative way of the environment of your consultation. Those orchids around, flowers around, this casual dress code, colorful. Maybe patients feel less stressed when they are in front of you, or they feel like more at home, like when they go to visit the doctor. That's one thing, that you go to the doctor and you are always stressed with that list of in your mind of things that I don't want to forget anything that I want to ask him, and then you get there and the doctor is very, let's say, aggressive in front of you, saying what will happen, what do you think, but how is it, and then you always forget some of your questions. Maybe that environment that you have created in your consultancy helps patients to get less stressed, calmer, and in a much easier way to approach the consultation. I also like that you have this lady in communication, that it's clearly it's more and more engaged, because I think communication is extraordinarily important for us, especially when we want to give visibility to this disease and this situation, and also when we want to break this stigma in front of society or lay people. And you tackle one other thing, which is suicidality. You tackle many things, but I just wanted to say those things because suicidality and cluster headache have been always very related. We know, many people, we know that it's called the suicide headache, in fact. So it has a strong relationship. Let me put you some questions. What is the challenge? What challenge do you have to treat to approach those treatments, or to approach this mental health part of the disease of migraine or cluster headache?
So one challenge is certainly time and money. So also we have, of course, problems with costs in our healthcare system. And whenever there is a public debate or newspaper article or something, it's on, I guess, like 95%, it's about costs. And almost nothing about return to the society, return to the patient, benefits. So that's one thing I really challenge from the community. So try to tell them we need the system, we need the time, and it also costs a little bit of money. It's not very expensive. In Switzerland, healthcare costs are estimated to be like 800 million Swiss francs, which is roughly about 850 million euros per year, but only 15% are direct costs such as medication and medical treatment. The rest is, of course, absenteeism, and even higher proportion is presenteeism. So we really try to work on that and make the insurance and also the regulators in our capital clear that please leave us just working. We do a good job. We care. We are here. We do after extra hours if needed. But we cannot not solve every problem in 10 minutes like they think. So that's certainly one of the biggest challenge to keep up my high standard despite constantly lowering medical income. And the other challenge, of course, is this huge increase in regulation. So asking for every medication, you have to ask the insurance, and usually, you know that, so you have a form with a few boxes and you tick the right box, and then they say, okay. It's absolutely useless and senseless, and it costs a lot of money, but we have to do it. And many patients do not get the medication. For example, Swiss Medical Board asks for 8 migraine days per month, and officially it's inclusion criteria 4 migraine days per month. So we have these huge restrictions also on past medication, which is a problem for young patients. They don't have beta blockers. They don't have used anti-epileptics, etc. So they're fresh, but they need the medication. And that's one of my biggest challenges, to try to provide patients with new medications and really according to their needs.
Yeah, this is something that it's extraordinarily important, very, very important, and I am always fighting for. It's to how to is access to those treatments, new treatments, in a much easier way without all those burdens that we have to get them. And politicians or whoever, or payers, or whoever pay or approve our treatment, they need to think that every single day of a delayed day, it's 24 hours of our life, and 24 in a week means so many more. And for each day that they delay the access of the new treatments to us, we suffer so much time of our life, and it can get so complicated in the future. So they really need to move the needle there and make it much easier, make the process much easier to access to the new treatments. Time it's very important. Of course, we need to be listened. There is no other way to diagnose our disease than what you say anamnesis, but we say to speak to the doctor, the patient. So there's no other way, and we need to feel that the doctor is interested in what we are saying, and that it's interested in us. Very often you go there, you see that doctor is in front of the computer, they are not looking at your eyes or anything. You are just telling once more your miserable history in your life, and you, in some occasions, leave those rooms with thinking that, well, once more nothing is going to happen, he has not listened, he's not interested. So this personal interaction between the doctor and the patient. It's really important, and time and money, I guess, I imagine, of course, for materials and for everything is important, but time and devotion from the doctor to the patient, it's really, really important. I'm going to involve all of you, so if anyone else wants to give an opinion about what we are talking, please put your hand, and I will ask this to Professor Agosti, or we will include it into the conversation. We have very important people among the audience. I'm seeing by the questions that are coming in. We have Professor Leonardi. Thank you for being there, Professor Leonardi. I'm going to encourage you. I'm going to engage you for our next webinar like this one. You tell us there, I'm coordinating a review of suicides and neurological disorders. There is very little on this topic for headaches. Thank you for this communication. You are leading now. You say that you are coordinating a review of suicides. That's very important to speak about, and we have had it hidden for many years because it was like, no, don't say anything about that because it gets contagious and it's worse. But I think it's the opposite. It's more and more people get committing suicides, and we have to speak about it, and especially how to prevent and help them to understand life and not to go into such a desperate situation. So for our next webinar, I encourage you to participate and tell us about this. I know that you work a lot, and not only in that, in so many other areas, and you have a big experience on that. There's some people that are asking about the dementia topic, whether to have migraine can develop a dementia afterwards, or whether it's easier to connect migraine with dementia, or those mental health problems and migraine with dementia. What do you think, Professor Agosti?
Unfortunately, it's
No, tell me that no. Tell me that it's no. I just need to hear no, not that yes, but tell me.
Of course. Unfortunately, it's a clear no. So I almost never see that combination. Almost never. So fortunately.
So it's not clear that because you have migraine, you will get you have more possibilities to get a dementia, isn't it?
I have a hard time believing these data, because if it's not evident for us clinicians, and if it needs a lot of statistics, then I'm very suspicious that there is not much about it. And indeed, I don't think so. I don't think it's a big risk factor for dementia. So again, I've seen patients getting really older in my practice. Actually, I have maybe a handful, but that's certainly average or even less.
Yeah. So, and we have another thank you, because that's enough relief. We have another question. I would like to thank you for the interesting presentations. As a physiotherapist, I'm interested if you use oxygenotherapy at your practice, or any other physiotherapy treatment, including exercise and relaxation techniques, as part of migraine management. What do you think?
Thanks for the question. And it's of course a standard question, whether I use this wide spectrum of physio, also complementary to alternative, whatever therapies. I mean, the non-medical therapies. And for a while, I had a craniosacral therapist in my practice. But since we are growing and we need a space for doctors, we don't do this personally. However, I have a network. And speaking of physio, most important thing is to know whether the physio has an idea about migraine, or maybe suffering from migraine herself. So whenever a patient says, I had physio, I had other treatments, especially the ones with hands-on physio or craniosacral therapies and others. My first question is, are they experienced in migraine? And that puts together my really nice network where can people refer to. We serve mainly Zurich and the region, but we also have people from all over Switzerland. And with now social media, it's not a problem to find therapists. In terms of oxygen, I don't do these therapies in my practice. I'm always interested in doing it. And I don't have a very good system to get feedbacks from these different therapies from many patients. But we work on it to have a better feedback on the treatments. So I cannot say more than that, but I have a big referral network.
Okay, all right. And one more question is, are there any type of medication for ADHD which not increase migraine attacks or headache?
Yeah, there's certainly not one, but try it out. So it's not a per se exclusion. Try it out.
But is there a type of medication for that?
I think it's a lot of dosaging. It's a lot of kinetics. But I have numerous patients doing actually sometimes even better, let's say on stimulants. So it's not a clear statement I can do on that use this or that.
All right. And what is the view on using HRT as part of the migraine treatment option for women who experience worsening of migraine pattern post-menopausally?
Same answer. Find a good therapist and try it out. Try it out. It's so complex and it's full of surprises. So for years I had a very nice collaboration with Gabriele Merki-Feld. We also had several publications, for example, on use of progesterone, gestogens instead of estrogens. And she's now retired. She's still somewhat active, but fortunately, we found a young gynecologist who's very interested in the topic, and she's kind of like part of my network. We have done a very interesting, successful seminar, like hybrid, just before the summer break. And the thing was, the topic was her health. It's a series of seminars, and the first one was on migraine in women, actually here at the place where I stand at the moment. And the new contact was now joined the team, and I'm really happy to have now an expert in Zurich where I can send patients to. It needs an expert.
Well, that's really, really to be remarked. It's that we need better experts and more experts in those fields, in mental health and migraine or headache disorders. Really, it makes a huge difference if you go to someone that knows what it is about and that it's an expert, or if you go to a general neurologist or a general GP or a general practitioner that has not a huge interest in this matter, because those diseases are very tricky, are very, very difficult to treat. They are not so easy. There's not just a protocol with a tablet after the other, that's it. It has a lot of combinations, a lot of relationship between the doctor and the patient, and it really needs a lot of interest and support from the doctor. I have a tricky question, difficult question here that I'm going to put you. Let me see. It's how can integrate health approaches be designed to better support LGBTIQ people in countries like Uganda, where stigma and discrimination limits access to care for those living with migraine and mental health challenges?
Yeah, I have no ready answer to this. It's a very interesting question. It's also a very important question. I know Zurich has a quite a remarkable LGBTIQ plus community, so I'm sure some person interested in that topic, they could learn a lot in Zurich. But I'm not the expert at all. So.
If anyone in the audience has something to you can put it in the chat and I can read it if you have any input, because as I say there is very special, very friends of us, very good friends of us, doctors from such as Kalina, for instance, from Mexico, who is a neurologist specialist in Mexico and is also the advocate. She plays the role of advocate for the patients in Mexico, and she has been writing some things here, and so she's listening too. If you have any experience with any of the questions, please go and participate. I'm going to give the floor to. We need to finalize this webinar, trying to find some strategies for integrated care. So don't leave Reto, please. But I'm going to give the floor to Claire Bradley, who is a person that lives with this experience. And like this, she can tell us a little bit about the burden of her life and how it goes. And then extraordinary psychologist and vice president for the Liaison for Mental Health, European Federation of Psychologists Association, will be speaking after Claire. So please, let's, Claire, the floor is yours.
Before Claire starts, Claire, apologies. We have a video stream that we would like to share from our campaign from last year, which we had planned for the whole session itself. So before you start, I think it would be a good way to kind of bring you in to bring in the lived experience part. It's a video that was done from one of the patients living with mental health and migraine we did last year. So we're going to show that video and then you can now come in. That's okay. Thank you.
Perfect. Yeah.
I am Alessandra Sorrentino and I live in Italy. I am president of Alleanza Cefalgici, a patient association that supports people with migraine or primary headaches. When I have a migraine attack, it's like I am inside a dark tunnel from which it's very hard to get out, because for a whole day I'm not able to do anything, not even to stand. Time stops, while out there the world goes on without me. And to manage the pain, what I can do besides taking the medication is to stand still in the darkness, in silence, and wait for the pain to pass, trying to limit the frustration and to welcome this moment of forced stop, knowing that sooner or later it will end. For many years, I experienced the stigma as an unremovable label pasted on my t-shirt. The loser, the lazy one, the one who used headache as an excuse not to go to school or work, the one who couldn't play sports like everyone else, the one who was always sick. In high school, I was bullied. From some companies, I was forced to leave. Migraine does not define me, but it's a part of me. It has also affected my mental health. No one should be ashamed of having an invisible disease, and no one should hide when taking care of mental health. If you want to support people with migraine and people experiencing depression or anxiety, the first thing you can do is listening without judging, because empathy makes us feel welcome instead of alone, guilty, and rejected.
Extraordinary testimony from Alessandra from Italy. And very touching. Really, really, it's impossible not to get touched after listening to her story. And that's the story of so many other people. So this is what we are doing here, giving voice to the sufferer ones, to the ones who really, really are affected for that. Thank you, Alessandra, for that. I don't know if you are here today. I know you very well, and we have a comment now saying we have a lot to do. Yes, we have a lot to do, and we won't stop until we'll change things. Things are changed, and so that's why we are here. Join us, join the EMHA or GAMIAN, or join our organizations to give us also your support, your testimonies, and your help. So I'm going to give the floor to Claire. Claire, what
Hi.
happened to you? Yeah.
Hi, Elena. Lovely to be here today, and thank you very much for the opportunity to speak on behalf of the lived experience. And I see Pat Little on the call. Pat, hi. You're about to be shocked to find out that my daughter, who is one of the family who suffers from migraine, who Pat knows, is now 32 years of age and has suffered with new daily persistent headache for 13 years. So I have an experience of not just being a chronic migraineur myself, but also of being the mother of someone with a very disabling form of it who has never met their potential in life. So from a mental health perspective, it affects all of my family. It affects those who suffer, but also those who care. And I think, one of the challenges we as a family have experienced is the lack of ability to access the care needed to ensure that we can all be resilient, we can all cope with the challenges that having migraine brings, having the inability to necessarily address and influence that a chronic condition. And we try as a family to remain resilient, to support one another, but without access to psychological support in doing so. My daughter, for example, has been 8 years waiting to get psychological support here in Ireland. She has a wonderful neurologist, wonderful GP, but none of them seem to be able to influence access to those particular services. So hearing on this call how the wonderful speakers have been gathering data to inform future decisions on that is really important for us as the patients. Hearing actually the wonderful setup in Zurich, it makes me so envious. It's so brilliant. Not just from the psychological support for us, but also I myself, for example, now that I'm at an extremely chronic level in my condition, I'm suffering from challenges in workplace. So it looks like I'm likely to have to retire 6 years early as a consequence of that. I have a multinational employer who is trying their best to understand the condition, but unfortunately failing massively. And there are insufficient services to help them understand how their decision making, the delays for the last 2 years in giving me support, is impacting my mental health. Occupational assessments may give them those diagnoses, but they then don't know what to do with them. So it's not just about informing and educating GPs. That's hugely important. The GPs here get 4 hours training in headache. That is it. But it's also the fact that when you then try and access the services, that My daughter, for example, has to re-educate every single time she goes to a new GP. And again, not able to access the services. So we both pay privately for therapists, and that does help to some degree, but it's not the same as having that holistic treatment program that we're speaking about today, and that I'm passionate about getting, not just for us as a family, but for everybody who is on a journey with migraine, whether it's episodic or chronic or of the more new daily persistent headache permanent impact perspective. So all of those things really just for me and for my family show how strong we are. But that strength is something that I feel is very vulnerable. It's something that am very worried about myself. And it's something that I believe may be not a bottomless pit by any means, but a very finite resource that we have as a family.
Oh yes, Claire, you tackled 2 points, two extraordinary important points here. It's again you said very important things, but I want to speak about the importance of your family and your relatives around you. How important is that you are close to your daughter and that you have your support also, and that also you have migraine and you are supporting your daughter, and how important is that your environment understand and empathize with you and understands you and can help you. And this vulnerability that you mentioned just now is also an important issue. We are very vulnerable. We feel that we are very strong. We are very strong people. I have this. I always say that we are much, much stronger than anybody else, because at the end we have the same life than anybody else. We don't say anything. Our disease is hidden. Nobody help us. Nobody support us. And but we have also our migraine, our disease, our condition. So we are very strong people, but at the same time we are very vulnerable. So we make we make those waves in which we feel very strong, and suddenly the pain hits you, and then you become down in the in the in a situation in which you cannot affront your life, no? And it's important that someone gives you their hand and takes you from their hand and say, come on, you are going to get it, you are going to get there, you are going to um, to succeed with that pain, you are going to come out of that dark moment or chronic moment or bad situation in which you are. We have a lot of questions now. I don't know whether to put the questions, or I'm going to give the floor to Dr. Francis Leader, and like this, and at the end of when you speak, I will put you all those questions that have come up now, and then let's see how can we improve this situation, or what are our new ideas. All brains, all ideas are good and are necessary to improve the situation. So I'm going to give the floor to you, that you have been waiting for the whole webinar, Dr. John Francis Leader. Thank you very much. Please let's us hear you and tell us what is your input.
Thank you very much. And my compliments to the organizers and the participants for the webinar. I've been, I don't know if enjoying the word is the word to use, because it's very challenging, I think, to really connect with the reality of a topic like this. But I think it's incredibly valuable, because to have this mix of lived experience and professional experience on this topic coming together and just to give a voice and to shine the spotlight on it is immensely valuable. So sincere thank you to everybody involved. I'm here on behalf of the European Federation of Psychologists Associations, which is an umbrella federation of the national psychologists associations of 37 European countries, so including all 27 EU members. So as you can appreciate through psychology's work, this is a really important topic area, actually in both sides of the equation, because the topic is migraine and mental health. So we have psychologists that work with migraine and pain management and so on. And we have psychologists, of course, with mental health. So this is actually coming from both angles in a way. So it's a very interesting topic. In terms of migraine itself, we've used a number of words today like comorbidity, bidirectionality. Really, the systems approach of the various elements coming together, I think, is the important bit. And I think one of the unfortunate themes we've seen is that while reality and the challenges we have might be bidirectional, often our systems, our healthcare systems aren't. They're separate and they're segmented. So I think that's a huge theme that's come up today that I would definitely echo from the experience of our members, is that very often this segmented approach is part of the problem to having a more holistic systems-based approach to be able to meet people's needs and to help them. So internally, there can be a number of things going on, and externally, the role of family, workplace, etc., as has been mentioned. So none of these things happen in a vacuum, I think, is a really important point to recognize. And that's challenging, but there's also some opportunities in it, because certainly in my own practice, I describe it like a jigsaw. So how can you maybe work on one piece if you can't work on another piece? You know, where is the way in? Something maybe harder, but we can maybe focus on something else and try and have an overall positive effect then where that's possible. So there obviously are a range of psychological therapies that are engaged and used, but I think there is no one-size-fits-all solution. So having that real individualized approach is a really important part of it too. So just to touch upon the policy level a little bit as feedback, very much taking a biopsychosocial approach. So thinking about not just what's happening in the body, but in our thoughts, our feelings, and the context and the environment we're in is really important. Among some of EFPA's priorities in this area, one is an all policies approach to mental health. So making sure we're looking at it across a range of different topic areas. Also societal crisis response. So remembering that in addition to whatever problems we're having, there are additional societal crises that happen that migraine sufferers are experiencing as well. So these compounding effects really need to be taken into account too. A big emphasis on the role of community-oriented services. And then a big focus on the workplace, as been mentioned a number of times, because it's a place that people potentially spend so much time, and really trying to support that. Another thing we're active on is training standards and regulation. So is the education, is the knowledge really there for practitioners, both to develop their own competence, but also to appropriately refer as well when needed? And then the one other thing is the role of accessibility and also the role of digitalization in that. So there can be pros and cons to that as a topic, but potentially there's some opportunities as well in terms of accessing expertise and supports there too. So the final point I'd make just is to emphasize some of what was said about resources and access to services. So I think there's a few issues there that are coming together at the same time. One is just purely the resource issue. So Claire, you touched upon that there. I mean, are the supports actually available in Ireland or versus Zurich or versus anywhere else? So them existing is one thing. But I think the big thing we experience is even if they do exist, they're maybe not integrated, and it's very hard to find them and move between them. And then even if they exist, and even if you can find them, the actual navigation of booking appointments and actually the user experience in a way of the best of times trying to navigate through those systems and arrange appointments and follow-ups going to be quite challenging. So I think that's something we really want to see, is this real systems approach to helping to resource and navigate the relevant supports for people. And also that point about real co-creation as well. So it isn't just a specialist over there and we're all waiting, but actually the community can support, individuals with lived experience can support, and various professionals can support if we can coordinate amongst each other. And I think that's a better outcome for everyone. So thanks again for the great work in this area, and great to see it continue.
Well, thank you very much, Dr. John Francis. You summarized very well, and you gave us emphasized again the importance of creating those coordinating departments of mental health and neurological disorder. It's what they exist. You said something. In some cases, they already exist. It's the lack of this coordination what is missing, and it's what we maybe could push to create, or push to um, to to create this importance, to raise up the importance of those services for patients, because really patients they need it. You also mentioned the workplace. The workplace is so important. It's extraordinary important topic. We created at the EMHA, you all know that we have this migrant-friendly workplace award that we give, and we give to the places, to the workplaces that are willing to look after their workers with migraine. It's important also, and those workers with migraine, they also have mental health. It's true that when you go to rise up to that level of migraine and mental health or depression or anxiety, it's impossible to work. But you need to live and you need to earn your life, which is for me the more tricky situation. How do you do if you can't? But you have to do it. You must do it. There's no other way. Nobody else is going to support you, because politicians, the governments, they are not ready, or they are not prepared to support that group of people. How do we do it? We can't work in that situation. The companies don't want us. They are going to, as Alessandra said, they are not going to hire people like with our situation, but we have to do it. We must do it. So this is an important topic. How do we move that needle there, that we could improve that situation? Now I'm going to open the floor to everybody for ideas of how to improve this situation. Which strategies do you think for integrated care? How do we improve the life of this group of real affected people that need our help, need our support? So let me give the floor to all of you. Is there anyone that wants to speak? Or another thing that I'm going to do first is going through the questions, because like this we don't leave any question without answer. And I think they are for Professor Agosti. Do you have any experience with pain reprocessing therapy? Does it have good result? Reprocessing. Do you understand me when I say reprocessing, Reto?
So I didn't understand your question. Experience with
Pain reprocessing
no,
therapy.
no, I don't have. So
Reprocess.
yeah.
Reprocessing therapy. Do you have any experience? No.
No, I don't know it.
Do you know what it is?
No, at all.
That's a good point.
It's interesting that I don't know.
No, I don't know it either, and that's why it's the Dr. Francis Leader. Do you know what pain reprocessing therapy is?
I can only speak more generally rather than on any one particular technique, but what I would say is I like to use the analogy in this work of physical fitness. You know, if somebody wants to be fit, there are definitely many ways to be fit, but which will be the correct or the incorrect way will massively vary depending on the person. Rugby for one person, Pilates for another person, hill walking, etc. So I think in conjunction with a good qualified practitioner, but also really the listening to the lived experience and that certain trial and testing, I think that should be a good foundational approach. And then from there comes the particular technique.
Yeah, right. You are completely right. Yes. So it's a very personalized treatment. Also, we need to create or enforce this personalized treatment for the future. Someone in Poland said that this is a very important topic in Poland. There's 25% of migraine patients that have depression, and 21 have anxiety, and there's a lot of work to do there. Someone is clarifying what's pain reprocessing therapy. PRT is a psychological treatment for chronic pain that retrains the brain to reinterpret pain signals as non-threatening, aiming to reduce or eliminate the pain by changing the neural pathways responsible for chronic pain. Grounded in neuroscience and psychological research, PRT provides techniques to help patients understand their brain's role in pain, feel safer, and use tools like somatic tracking to process emotions and sensations. Studies show that PRT is effective with significant improvements in pain level, including long-term relief by shifting the patient's understanding of the pain experience. Yeah, it's like a resetting the brain, I would say. It's talking to our brain and resetting the brain and creating new pathways and new brain cell communication, and tell them, I would say I have heard about that, and then try to change the information among our brain cells, and make them try to make them understand that the response or the action is not right, and they have to change to a different one and to reset them, I would say, which I think it's extremely difficult. Extremely difficult. I've tried to do that, and I think it's extremely difficult. It can, I don't say that it cannot happen. I don't know. Reto, what do you think? Can we reset our brain?
Of course you can. So it's a matter of training, like you train for other things. So if you first time standing on a skateboard, for example, no chance that you can do it, but you learn it. And dealing with pain is also an extremely interesting thing you can really work on. And every time I have an acute pain, first, of course, I swear out loud, but then I'm fascinated. So like, for example, a wasp sticking me in my thumb just before I leave for vacations. But then I observe myself, what's going on in the acute phase, and how the pain is spreading to my thumb, and it's spreading to other things. It's spreading actually to my pinky. So, and then of course you can talk to your pain. Sounds kind of like crazy, but you can do a lot. And I personally trained in focusing, which is kind of like a technique developed by a really interesting, of course, diseased German, Austrian psychologist in Chicago, well, people of Carl Rogers. And he's focusing is kind of like internalizing a lot of stimuli, and you can really work of it. So I trained in Switzerland, I trained in the US. I'm a certified focusing trainer. You can look it up in the webpage. But while I trained in the US, we started to do focusing partnerships, and happened to have a really cool, interesting person in the focusing group. And we had a deal that whenever something happens in terms of pain, disease, belly cramps, whatever, we call each other and we do focusing together. And it can be at 3 a.m. And once I had really terrible abdominal cramps, and we did focusing together. It was amazing. So I think you can do a lot.
Okay, so we need to reinforce that therapy, that type of therapy, also the PRT, and also, and nothing is crazy, so everything can be possible, and we need to create ways to access that for the patients.
It's like using, like learning a new language. So the first steps are really hard, but then you do it and do it and do it, and then it gets better and better and better. Same with these techniques.
Okay, let's go. Let's study about those techniques.
Yes, Elena, we have two people from the audience that's raised their hands. That might be nice to yeah.
Yeah, I cannot see them. Yeah.
But there's Deborah Nixon and Stefan Winkler. So if they're still there, maybe we can give Deborah. Yeah.
Okay, Deborah. You are muted, Deborah. Right. Please go ahead. We cannot hear her. We cannot hear her.
We can't hear her. No. Okay. Well, okay. Yeah, Deborah is the only person now. I think the other person just took down the hand, but Deborah is not there. She's muted still. But
Okay. Well, I
Okay.
want to thank you all for this very good, very good webinar. I'm going to give you the floor to close, Nigel. I think we have a lot of information. It's true that I left open that question of how do we create strategies for integrated care. The question is there. I don't know if anyone of you have the result, the solution, or the idea of how to do it. But please send it to us, and we'll try to work on that.
Okay, just as a brief comment on that, I'd suggest we're already doing it in a way right now. So it's really to continue this kind of conversation and to do potentially a poor job, but better a poor job than no job at actually mapping what it looks like and really trying to push for it in policy at every available opportunity. So it is complex, of course, by definition. These things are complex topics, but at least if we can get away from this idea of trying to deal with them separately and we can have this idea of interprofessional, lived experience, etc., coming together, then we actually have some chance. And actually the economic arguments we've heard today are very powerful as well, because it may actually be too expensive not to do it, even aside from the human suffering involved. So actually for both angles, it makes sense.
Yeah, thank you. Thank you very much for that. That's a very good point. Nigel, we are on time already. I'm going to give you the floor.
Well, thank you, Elena, and thank
It has
you,
been an
everyone.
extraordinary webinar.
Thank you, everyone, for joining today, and thank you to the panelists for all your insightful and inspiring words. I think it's good to hear this every time, and for us to continue to advocate and do the job that we do to make sure that we bring migraine and mental health to the limelight, with the hopes that we can push for some policy changes in a lot of the European countries that we work with, and also not just with our member organizations, but other stakeholders. But we look forward to welcoming you again in other future activities. And for those that joined quite late, we have done the recording of the webinar, which we will have on our website. I will be also happy to share the PPTX, the PowerPoint presentations from all the speakers with the participants. If you need it, we'll be happy to share it with you. So thanks once again to everyone, and it's been a lovely webinar. It's been a nice day. It's good to see a lot of people in the audience. We had over 90 participants, which is great. And so it's exciting to know that there's a lot of interest in this area. So I would like to say again, thank you, and wish everyone a lovely day and a lovely evening. Thanks, and see you again soon. Thank you, Elena, for the good job.
Thank you.
It's always
you.
wonderful to have you.
Thanks a lot.
Thank you so much.
Thank you.
Bye.
Bye-bye.
Bye-bye.
It's recording.